Hello, everybody, and thank you for joining the Dr. Mike and Shannon Show. I am Shannon Fanestein, medical technology specialist with Mazan Medical, representing the Uraval BRS. And we are joined, as always, with Dr. Mike Bradley. Dr. Mike Bradley, go ahead and introduce yourself to those who might be new joining our show.
It's literally in the title name of our Dr. Mike and Shannon show. So it's always fun to be introduced, with this, because it's like literally in the name. But I'm Dr. Mike Bradley. I'm the Chief Medical Officer of Mazan Medical. I'm also a certified pelvic floor specialist, working out of Las Vegas. And we're going to talk about some fun things that I like to talk about today, which is pelvic floor rehabilitation therapy. So super excited about that.
Well, and today, so we have talked a lot about pelvic floor therapy, pelvic floor rehab,
right?
But we've never talked about what is the difference. Are they the same? Are they different? How are they done? Are they for men? Are they for women? What is it? Go ahead and do a deep dive today into this.
This is a great conversation, because it's even in the medical school that I work in. The physicians that work there and the students that work there, they say, "Oh, Dr. Mike, the PT, the pelvic floor PT guy." And I'm like, "No, I'm not a PT guy." But it's not that I don't love our pelvic floor physical therapist. I'm a pelvic floor rehabilitationist, closer to a physiotherapist than a PT person, if that makes sense. So let's talk about the difference. There are two categories in pelvic floor rehabilitation. There's physical therapy, which is mostly revolving in the muscles, the major muscle movements. A lot of people know occupational therapy is the smaller movements, right? Or there's rehabilitation. And with rehabilitation, you're doing the pelvic floor physical therapy at home and on your own. I, as the rehabilitationist, is assessing your processes and whether or not you're doing a good job, or whether or not the treatment strategy that we chose for you is actually working or not, and customizing every week of therapy based on what you, the patient, are able to actually do. So there's a big difference there. There's a difference in both the scope of practice. I'm underneath the direct supervision of a medical physician based here in Nevada. All of people like me are under direct supervision of a nurse practitioner, provider, or higher within their individual practices. Whereas a PT is under their own scope of practice. They're a physical therapist. You go to a physical therapy office. They do physical therapy on you. They bill for physical therapy codes. It is separate. I'm done in the clinic. It's more of a clinical kind of a process. A PT person is done as a physical therapist in a physical therapy office. And so let's talk about, now that's the difference between the two, right? There's PT on this side doing, pelvic floor rehabilitation, PT, and there's Dr. Mike over here doing physiotherapy, pelvic floor rehabilitation, specifically rehabilitation, right? With assignments of exercises or physical therapy to do at home when you leave me, if that makes sense. Okay.
But they also use, I know that they have like pelvic floor stimulators. Is that part of both?
Yes.
The pelvic floor therapy and the pelvic floor rehab?
So within the scope of what a physical therapist can do, they are more on the guidelines of not assessing. The assessment should be done by the doctor who prescribed the physical therapy. They are there more for the process of being able to strengthen the muscles and fix the symptoms that the weak muscles create. Whereas on the rehabilitation side, we're actually assessing the strength of the muscle based on exercises done somewhere else, almost where we would refer to physical therapy. And then they would come back to us and we would be doing constant assessment of whether or not the technique that the physical therapists use is working or not. Now, within both scopes, pelvic floor rehabilitation and pelvic floor PT, that you see a lot of EMG and you see a lot of electrical stim. The difference usually is in what they call manometry or biofeedback. A pelvic floor physical therapist will use something called biofeedback to be able to determine if you're doing the proper exercises, you, the patient, are doing the proper exercises, and help you make sure you're doing those muscle exercises correctly, right? Manometry is more about whether or not the muscle, how much the muscle can hold in strength, how much endurance the muscle can hold, and whether or not there's spasming happening when you relax the muscle. This is not determined by biofeedback. Therefore, it is not within the scope of practice, generally speaking, of the physical therapist. Physical therapists are billed based on time, essentially, how long they work with the patient. Doctors are generally billing based on procedure, a CPT code procedure associated with a diagnosis that helps to fix that particular problem. So there is a definite difference between what we do, even though from a layman's side looking into it, you would almost think they're somewhat similar. We are still doing stimulation therapy, just like the physical therapist would do. We are doing EMG like the physical therapist do, but we do it on more of a study basis than a helping the patient to not use the wrong muscle basis, right?
So when would a provider refer to pelvic floor rehab versus pelvic floor therapy?
Generally, what happens is a pelvic floor rehabilitation program is placed in the doctor's office, whether it be I've done this in urgent cares. I've done this in at the School of Medicine, of course. We've seen this at OBGYNs, and we've seen this at urology offices. These are specialists who work with patients that have incontinence or pelvic problems. So therefore, that's a place where you would generally see a pelvic floor program designed to fix those particular patients. For a general practitioner, the direction, generally speaking, is just to send off to pelvic floor PT if you have a patient who has pelvic floor issues. If the issues are severe enough, then a primary provider, a primary physician, would refer to a urologist who would then say, we are going to treat this in-house because it is bigger or more complex than what a standard PT program can handle. And I would say the major reason for that is because PTs generally don't deal with neurological problems, whereas a pelvic floor rehabilitation will look both at the muscle physical problems, but also the neurological aspect of what's happening. And that gets us into the conversation of the bulbocavernosa reflex. Why do we keep talking about that test? Well, if you're like a general practitioner and you're dealing with a lot of incontinence patients, you deal with like a lot of geriatrics or something like that. If you can,
Or internal medicine who does do
medicine, like any kind of general med, where
Yes.
your go-to is sending them off to a pelvic floor physical therapist. That may not be the right move because you might be dealing with a neurological issue and not a physical issue, a muscle strength issue. In that scenario, using that bulbocavernosa reflex system that we talk about all the time would make a lot of sense, because then that doctor can assess, right? The BRS is an assessment of whether or not they're dealing with incontinence based on a neurological issue or incontinence based on a non-neurological issue. That being said, if I have that information, general practitioners, I can direct a person to a pelvic floor rehabilitation program at a urologist or a gynecologist versus sending them to a physical therapist who would not be within their scope of practice to help that patient, right? So that's why a lot of physical therapists fail, is because they're doing a treatment that's not neurologically directed. It's physical directed. And so
And
that's
it's not their fault that they're the ones who are getting sent this referral. And it's coming from the referee that's not understanding what the problem is.
Yes.
And so unfortunately, that means then this patient is most likely not doomed to fail, but has more of a chance that the outcome's not going to be beneficial.
What we've seen with people that have neurological issues who go through a biofeedback program, non-neurologically directed, is that they're good while they're doing the physical therapy. And then a few weeks go by after they stop their 8 to 10 to 12 visits with the physical therapist, and their symptoms all come back, because the symptom was actually the weakened muscles. That's not the problem. That was the symptom. The real problem is a spine problem or neurological problem or something that's causing the weakness of those muscles. So even if you strengthen the muscles up and you haven't solved the problem, all of those symptoms will return, and generally they return very quickly. So a lot of people say, oh, that PT, that physical therapy, the biofeedback, it doesn't work. They report that back to their doctors, so their doctors stop referring to that PT, which is really sad, because if the PT is given the right type of patient, they would be absolutely successful. But because they're given a lot of, even half of their patients are not the right patient, not only not successful, that referral source stops referring because they don't think that the PT actually works, even though it does for the right patient.
And this almost goes back to where we had discussed the Merck manuals, where, if you are a provider who is working with patients with incontinence, per the Merck manuals,
Yep.
they want to do a BCR test,
Right.
and check that, because that is one of the protocols.
It specifically says bulbar cavitostal reflex.
And
it's
this is
right there
for any provider. It doesn't have to be just a
Nope.
urologist.
Should
This
be done
would be for your primary care internal medicine.
It says this is what we do on adults with incontinence. It also says pediatric doctors, this is what we do with children with incontinence. So, when we look at this, the Merck manual, the last update was September 2022, and it is dead on what we should do as providers, as the guidelines state. And if you're not doing that, I highly recommend reaching out to us to talk about, our perception of what is really black and white in that manual, as the guidelines of what we're supposed to be doing as physicians within the field. So
and if you're a pelvic floor therapist out there, we want to be able to present this to you, because we know how valuable you are to patients. And we don't want you to be set up for failure because you are being referred a patient who is not suitable for what you're doing. We want you to have the success and be able to share that we have a way for your provider, before they even send that patient to you, is that a proper candidate for what you're going to be treating?
Right. If you're being sent the wrong patient right off the get-go, you're doomed to fail. And then it makes you look bad as a pelvic floor physical therapist. And I don't want anybody looking bad because we, as the physician, sent you the wrong patient.
And we're already short-staffed in my area as it is to begin with. So we need more of you, not less.
Or if you're a physical therapist who's given that right information that this is a neurological issue, that STEM therapy should be your direction. And so it can help you get better outcomes as a physical therapist if there's not a pelvic floor rehabilitationist in the area, and we don't see a lot of those that exist.
No, hopefully soon. We're hopefully going to be expanding that into other areas. So stay tuned.
Yeah, for those that are listening, we're looking to duplicate what I do at the School of Medicine. And that is where I think, Shannon and I are directing some of our attention to give this treatment that is so successful to the world, and that's what we're trying to do. So please feel free to reach out. If you've gotten to the end of this video, reach out and we'd love to talk with you.
And we want to thank you again for joining us today on the Dr. Mike and Shannon Show. Please don't forget to like, subscribe, and share. Share with your providers, share with your therapists out there, because this is truly important. We want everybody to be able to succeed in their proper care and the proper treatment. And we can't do that if you don't know what's out there and what's available. Any last words, Dr. Mike?
All I can say is that I just want to see everyone getting better, and let's help those people who know what they're doing have the information they need to do it even better.
And thank you very much. And everybody have a wonderful day.
Have a great one. Bye-bye.